व्यूशिप बंद कर देना फैन। किया मैंने, आई डोंट नो स्टार्ट वर्किंग जस्ट started. So hi guys, I hope I'm audible and visible to you. Okay, so guys, today we are here to discuss the recall questions of what you call as your recall questions. Yeah, that's what we are kind of going to discuss, which you had the exam very recently. So can I just get thumbs up from you guys in the comment box whether you am I audible and visible to you in a proper manner or not, or something like that. So yeah, I hope I'm audible and visible to you in a proper manner. Okay, now what we are going to do is we are going to okay, that's great. So hi Bidhi, good to see you. Right. Hi everyone. Okay, now guys, I have a set of 10 questions in front of me which I will be discussing with you guys, but I want your help. I want your help a bit. I want you help in telling me that whether that particular question is accurately being recalled or not, and whether the options are kind of relevant or not, or something like that, or whether the options were the same or not, or something like that. For these particular things, I need your help. Okay, so let's kind of start with these particular stuff and let's kind of see whether you guys had the same question or not. So what we are going to do, we are basically going to look at the NEET MDS recall 2024 for the surgery, general surgery, right? Now, the first question which you had was, I hope that this was the question, what is the minimum cutoff level of the platelet count below which you will not perform a routine dental procedure? Okay, a routine dental procedure in the patients with leukemia. Wouldn't have been a leukemia or something like that. So it should have been a patient with thrombocytopenia. Thrombocytopenia. Okay. So whether first thing which I want to ask you is whether here there was leukemia or not. Whether it was leukemia or not. And yeah, that is one thing which I want to ask you. And the first time when I received this particular question from our recall team, the option which was given were 10,000, 20,000, 30,000, and 40,000. What help I want from you guys is I want to know whether the options were this or whether 50,000 was one of the options. Okay, so can you please help me with this? Yeah, like what were the actual options, guys? Can you please tell me? I'm waiting for you. So, according to this particular question, the answer is definitely 50,000. Okay, the answer is definitely 15,000. I'll talk to you about these particular stuff. But yeah, let's kind of have an interaction for a bit and let's try to understand whether what was the kind of correct options and all those particular stuff. Let's try to understand that. Okay. So please put it on the comment box as well, guys. Okay, please put it on the comment box as well. I will be see. The point is that this particular session will last for approximately an 1 hour, 15 minutes or something like that. And I will be covering these particular 10 topics in pretty detail. But there's no point of me just kind of telling you or teaching you these particular topics as well. Just let's try to understand whether was not there. Okay, or not there. Okay, so the only options were 10K, 20K, 30K, 40K. They should not be spontaneously bleeding. Okay, so Lucky, was the question that the patient will start spontaneously bleeding below which particular platelet count? Was that the kind of a question? Okay, so guys, let's kind of talk to you about these particular stuff. Okay, so what we know about the platelets. Okay, what we know about the platelets. Okay, so 50,000 was not there on the option. Okay, and Saurav, can you please tell me whether the okay, so 50,000 was not there on the option that I understood. The options were 10K, 20K, 30K, 40K. I understood that. Now let me just understand whether the framing of the question was the same or whether the framing of the question was a bit different. Okay, so spontaneous bleeding should not be there was one of the options. No, that is not the correct answer. That's not the correct answer. Okay, so let's kind of talk to you about this. Okay, so what we need to know about the platelet is the normal kind of value of this particular platelet count is, let's say, somewhere between 2.5, 3 lakh, 4 lakhs, or all those particular stuff. But what we want to understand is we want to understand about the thrombocytopenia. Okay, thrombocytopenia. Okay, now what do we need to understand about the thrombocytopenia? So the okay, not the The question was leukocyte count or the platelet count? Okay, anyways. So the point is that I think that the question had the platelet count. It did not had the leukocyte count because there's no one particular cutoff of the leukocyte count below which we can go ahead and do the particular dental surgery or something like that. I don't kind of feel that. Okay, so forget about that. Okay, now let's kind of talk about this thrombocytopenia. Okay, so what you need to understand is, let's say if at all my hemoglobin is a bit low. Okay, my hemoglobin is a bit low. Then obviously if I go to the, let's say, I want to get operated or something like that, then there is a chance that the patient, like the doctor will give me blood transfusion. I might receive a blood transfusion. There's also criteria for that. If at all, for the routine surgeries, if the hemoglobin count is less than 8, then you kind of receive the blood transfusion before you undergo that particular surgery. For routine surgeries, the hemoglobin count should be more than 8 milligrams per deciliter. Okay, so that is what you need to understand. If at all it is less than that, then you receive the blood transfusion. Okay, but the same cannot be said for the thrombocytopenia. Okay, if at all the patient has a reduced platelet count, it doesn't mean that you will give the platelet transfusion. It doesn't mean that you're going to give the platelet transfusion. They're not going to give you that. Okay, why? Because what you need to understand is the lifespan. The lifespan of the platelet is, lifespan of this particular platelet is only 5 to 7 days. Only 5 to 7 days. So even if you kind of give the platelet transfusion, what is going to happen? The patient is going to kind of have the like the platelets will kind of get destroyed in 5 to 7 days, and again the platelet count will come back to the normal. So whenever you are dealing with the patient of a thrombocytopenia, whenever you are dealing with the patient of a thrombocytopenia, the treatment for these particular patient is treat the underlying cause. What is the treatment? The treatment is you have to treat the underlying cause. Okay, so you have to kind of treat the underlying cause. That is what is the kind of a treatment for that thrombocytopenia. What do I mean by treat the underlying cause? So let's say if it all the causes, let's say dengue, let's treat the dengue. Let's say if it all the causes splenomegaly, let's kind of address the splenomegaly. That is what you need to understand. But immediately the question is going to arise in your mind that when to do the platelet transfusion. Platelet transfusion. Okay, now what you need to understand is that if at all the platelet count is less than 10,000, if at all the platelet count is less than 10,000, the patients can have spontaneous bleeding. Okay, so patients can have spontaneous bleeding. And if at all the platelet count is less than 10,000, yes, the platelet transfusion is given. Okay, so platelet transfusion is given. Okay, so prophylactically, let's say I am a normal individual, I don't need to undergo any particular surgery or something like that. Then if I come to you and my platelet count is 1,000, yes, you are going to give me the platelet transfusion because there is a risk that I might land up into a spontaneous bleeding. Okay, but let's say if at all we are talking about the patients who want to receive a want to undergo a routine procedure. Okay, for the routine procedure, idealistically the platelet count has to be 50,000. Okay, if at all it is less than 50,000, you give the platelet transfusion. Okay, so you give the platelet transfusion. So what I mean trying to tell you that for a routine procedure, the platelet count should be at least 50,000. At least 50,000 platelet count is kind of needed. So if at all the options were 10K, 20K, 30K, 40K, the answer would be 40K because that is closest to your best answer. But idealistically, it should be around 50 to 60,000 for the routine procedure. Okay. Now, there are another thing. Another thing is, let's say if at all you are wanting to operate on somebody in which there is a high risk of bleeding. Okay, so there is a high risk of bleeding. Okay, so let's say if at all there is a let's say there is a brain tumor in which somebody who has to kind of operate for a brain tumor or something like that. So if at all you want to enter into the brain of that particular patient, at least 1 lakh. Okay, so if at all the procedure has a high risk of bleeding, then at least 1 lakh platelet count should be there. Are you understanding my point? So 3 MCQs, what you need to understand is spontaneous bleeding is going to start less than 10K. If at all the platelet count, if the patient wants to undergo a routine procedure, at least the platelet count should be 50,000. But as you're saying that that was not in one of the options, then your answer would be, let's say 40K. Because as per your options, that was the kind of the largest number. But if at all, let's say they say that the patient needs a spinal anesthesia, or let's say the patient needs to undergo brain surgery, where there is a high risk of bleeding. In that particular scenario, at least 1 lakh of the platelet count has to be there. Okay, I hope you have understood this particular stuff, guys. Everybody have understood? So that is what you need to understand about this particular question. Over here, the answer would have been 40,000. Okay, understood? Okay, now let's move on to the next question. Bacteria associated with the gas gangrene. Now, it was a pretty simple question. Now, this is a question which you can put into the category of microbiology or a pathology or a surgery or something like that. But it's a pretty simple question. I hope that all of you have answered this correctly, right? So what is the answer over here? The answer over here is Clostridium. Okay, so Clostridium is definitely the answer over here. So what is this? This is what is a patient who is having a gas gangrene. Now, the characteristic feature of a patient for gas gangrene is when you go ahead and when you palpate is, what you basically hear is a crepitus. Okay, so what you basically hear is a crepitus. Okay, so let's say there is a gas which is basically present in the subcutaneous tissue. So what you basically hear is a crepitus. Okay, so that's what you need to understand over here. Okay, now what you need to understand, let's kind of revise the kind of gas gangrene kind of very briskly. So it is the one which is having an anaerobic environment. So lack of oxygen is something which is the prerequisite for the proliferation of these particular organisms, because Clostridium is an anaerobic organism. Okay, so here what happens is the Clostridium, it basically enters and it is basically an anaerobic organism. So if at all the oxygen kind of supply to that particular area is less, that is what is kind of going to be beneficial for that particular bacteria to kind of grow. So there are also the spores which are basically resistant, which can remain in the soil for a prolonged period of time. And let's say if at all there is some kind of an injury which has been kind of contaminated by the soils or something like that, the spores can enter into that particular place, and that's what you need to understand. Okay, I understand. So you guys are saying that there was no option as 50,000. That's fine. If at all there was no option of 50,000, the answer would be 40,000. But idealistically speaking, around 50,000 is kind of needed. So see, guys, what you need to understand is science is not mathematics, right? So based on the options which you guys are recalling, the best answer would have been 40,000. Okay, so I hope you have understood this particular stuff. But idealistically speaking, 50 to 60,000 is the kind of range which you need if at all you want to undergo a routine procedure on anybody. Okay, but what you need to understand, spontaneous bleeding is going to start below 10,000, and yeah, like for the routine procedures around 40 to 50,000, 60,000, that is what is the platelet count which you will need. Okay, now coming to this, so the spore formation, yeah, that can going to happen. Now important thing is how does this particular Clostridium causes the destruction of the tissue? It is by the production of the toxins. And which toxin is produced? Alpha toxin. Alpha toxin is the one which is produced by the Clostridium, which is lecithinase, that basically causes the destruction of the tissue and produces the gas. Now, which gas is kind of present over here? So it has a combination of a hydrogen gas, carbon dioxide gas, and the nitrogen. So these are the gases which are basically present in the subcutaneous tissue. That is what you need to understand. And there is a rapid destruction of the tissue. And the treatment for this particular stuff is obviously there have to be a broad spectrum antibiotic, and obviously there's going to be an aggressive debridement. Okay, debridement. You have to get rid of whatever the necrotic tissue. That is what you need to understand over here. That is definitely has to be done. Okay, understood? Right? Okay, now coming to, okay, everybody understood? That's very pretty simple. Clostridium, gas gangrene, everybody is kind of okay with it. Okay, now coming to this, what is the TNM stage of an oral cancer? 3.5 centimeters with a distant metastasis and ipsilateral lymph node of 5 centimeter in size. So here, it really doesn't matter what was this particular size. It really doesn't matter what was this particular ipsilateral nodes or something like that. The moment they have given you that there was a distant metastasis, the answer automatically becomes 4C. Okay, so that's what you need to understand over here. Okay, so I'll obviously walk you through the TNM staging of the head and neck cancers, oral cancers, because that is absolutely important for you guys. So I'm definitely going to walk you through it. But here, if at all you would have been, let's say, a very vigilant person, if at all, like when you, it's a bit daunting to kind of remember all the staging and something like that. I'll tell you a couple of tricks, but you'll have to spend at least 10 to 15 minutes with that particular staging in order to, it really doesn't matter. Okay, it really doesn't matter whether this was 6 centimeters or 7 centimeters or let's say 9 centimeters or something like that. It really doesn't matter because they have given you distant metastasis. The answer, even if I would have put over here 2 centimeters or I would have put over here, let's say 7 centimeters, my answer wouldn't have changed. the answer would have been 4C only, because if at all there is a metastasis, the answer is definitely going to be 4C. Rest of the values are irrelevant. Okay, so that's what you need to understand over here. Okay, so let me kind of just walk you through it. Everybody knows, or every student of a dental, like who is preparing for this particular MDS exam, knows that the oral cancer kind of TNM staging is absolutely important for you guys. So yeah, let's kind of walk you through it again. And yeah, that's something which is the practice and all those particular stuff, right? So yeah, don't worry, that's fine. Let's kind of walk you through it. So pretty simple. What you need to understand is when we are talking about the T stage of this particular tumor. So whenever we talk about the T stage of this particular tumor, we have to look at two things. What are the two things? We have to look at the size of that particular tumor, and we have to look at depth of invasion. Okay, so size of the tumor and the depth of invasion, these are the two things which we have to kind of look at. Okay, now what about the size? So at the T1, at the T1, what you have, the size of the tumor is less than 2 centimeters in the diameter. Okay, so the size is less than 2 centimeters in diameter, and the depth of invasion is less than 5 millimeters. Are you understanding my point? So a size less than 2 centimeters, depth of invasion less than 5 millimeters. What about the T2? Over here, the size becomes between 2 to 4 centimeters, and the depth of invasion is between 5 millimeters to 1 centimeter. Okay, so that is what is a T2. What about T3? Oh, in the T3, what happens? The size basically becomes more than 4 centimeters, and the depth of invasion basically becomes more than 1 centimeters. Okay, so depth of invasion is more than 1 centimeter. Okay, so this is size and this is depth of invasion. So it's pretty simple. T1, T2, T3, less than 2, less than 5 millimeters, 2 to 4 centimeters, 5 to 10 millimeters, and let's say more than 4 centimeters and more than 1 centimeter depth of invasion. Now coming to the T4. Now the T4 is divided further into T4A and T4B. Now how you can remember it? Let's say if at all it is involving the surrounding structures which you can remove in the surgery or something like that, that is what is a T4A. Now this is a bit different for the lip and the oral cancer. In the lip, what they basically say is that if at all it is going through the cortical bone, or let's say the inferior alveolar nerve, or let's say the skin of the face or something like that, all these particular things you can sacrifice. So that is what is a T4A for the lip cancer. For the oral cancer, it invades the structures like the cortical bone. For the mandible, maxilla, involves the antrum and superficial invasion. I hope you understood, right? So whatever the structures you can sacrifice. Okay, so you can sacrifice these particular structures. But let's say if at all it is involving the masticator space or the pterygoid plate, or let's say the skull base, or encasing the internal carotid artery, you cannot sacrifice these particular structures. So if at all it is involving the structures which can not be sacrificed, okay, it can not be sacrificed. So that is what is your T4B. I hope you have understood this particular stuff. T1, T2, T3, T4A and T4B. Okay, understood? I hope you are kind of okay with it. Now coming to the end staging of this particular tumor. End staging of this particular tumor is also kind of very important. It has N0. Okay, that's fine. No positive lymph nodes and all this particular stuff. In the N1, there is a single ipsilateral node less than 3 centimeters. Single node on one side less than 3 centimeters. N2 is further divided into N2A, N2B, and N2C. What is N2A? It is a single ipsilateral node less than 6 centimeters. Okay, single ipsilateral node less than 6 centimeters. N2B is multiple ipsilateral on the same side less than 6 centimeters. Multiple. Okay, now what about N2C? N2C is either a single or a multiple ipsilateral nodes, one more than like not more than kind of 6 centimeters. So here also what you need to understand is, okay, now here no, I'm sorry guys. So okay, I just took a screenshot, but this is absolutely not right. So what you need to understand over here is N2C me, what you have is basically bilateral involvement of the nodes. I just took a screenshot guys. I kind of just for the sake of simplicity, I took the screenshot, but it's kind of, I think, the old staging or something like that. That's okay. So let's kind of understand. So N0 was this one, N1 was this one, N2A, N2B was this one, N2C may, there is bilateral node involvement, but again, none of these particular nodes is kind of more than 6 centimeters. So the nodes are basically less than 6 centimeters. Now N3 is further divided into N3A and N3B. What is N3A? N3A is basically a size of that particular lymph node is less than 6 centimeters. It doesn't matter whether it is a single node or whether it is, let's say, multiple nodes or bilateral nodes or something like that. Any node with the size of more than 6 centimeters, that is N3A. And in the N3B, what you have is an extranodal extension. Extranodal extension. That is what you need to understand over here. Okay. Now, guys, what you need to understand is that just revise this with me. It's very, very important. Let's kind of revise this with me. So what about the T staging? What we have in the T staging? We have T1, T2, T3. T1, T2, T3 means less than 2 centimeters, 2 to 4 centimeters, and more than 4 centimeters. Depth of invasion less than 5 millimeters, 5 to 10 millimeters, more than kind of 10 millimeters. Then we have T4A and T4B. In the T4A, it is involving the structures which you can kind of get rid of. Now, in the T4B, there is an involvement of the structures which you cannot remove surgically. Then in the end staging, what you have in one, there is an ipsilateral on the single side, single lymph node, which is less than 3 centimeters in size. N2 is further divided into N2A, N2B, and N2C. In the N2A, again, single ipsilateral lymph node, which is less than 6 centimeters, no extranodal extension. In the N2B, what do you have? You have multiple lymph nodes, but on the same side, ipsilateral nodes, and none of these particular lymph nodes is less than 6 centimeters, but you have multiple nodes. Okay, and then what about the N2C? N2C may you have a bilateral kind of involvement, but again, none of these particular nodes is less than kind of more than 6 centimeters. None of them is more than 6 centimeters. In the N3A, you have a lymph node which is more than 6 centimeters, and in the N3B, you have a matted node or extranodal extension is kind of present in these particular patients. Now, this is absolutely important. This TNM staging you have to kind of remember, but at the same time, you also have to remember the staging of this particular tumor. Okay, so now let us have a look at the staging. Now, the question which they had asked you, they had given you that the metastasis is present. So if you just look at this, metastasis is only present in the stage 4C. So your answer, like, or your question got over here itself. If at all the metastasis is present, it is kind of 4C. Okay. Now in the exam, you have to kind of be smart. So what you need to understand is T1, T2, T3. Okay. So stage 1, stage 2, and stage 3 basically means that T1 is stage 1, T2 is stage 2, T3 is stage 3. Okay. When we talk about the lymph nodes, if at all there is, okay, in the stage 1 and stage 2, there is no lymph node. Okay, there is no lymph node. So either the T stage is third, T3, or there is a lymph node involvement. So let's say the T stage is T2 and there is N1. So there is a T stage is, let's say, T2, and N is, let's say, there is ipsilateral lymph node involvement, 2 centimeters, mobile, no external extension, all those particular stuff. Then your stage is going to be stage 3. Stage 4 is further divided into A, B, and C. Okay. C, we talked about any kind of any N, any T with metastasis, that is a 4C. Now, when we talk about the 4A and 4B, what you need to understand, if at all there is a T4A, that is what is a 4A, and if at all there is T4B, that is 4B. Okay. Now, coming to the lymph nodes, if at all there is N2, that is kind of 4A, and if at all there is N3, that is kind of 4B. Okay, so whatever I have highlighted, if at all, like with this particular yellow highlighter, whatever I have highlighted, if you just go through this particular stuff, you will have to spend at least 5 minutes with this. But with this in your mind, you will kind of form some kind of a solution in which you will be able to understand what is the staging of this. Now, your question which you had come in your exam, it might appear very, very difficult, but it was not that difficult, because as I told you that if at all you would have paid attention towards this particular stuff, and you would have realized that if at all there is a metastasis, it doesn't matter what the T stages, it doesn't matter what the N stages, the answer is always going to be 4C. You would have got your answer in your exam. I hope you have understood this particular stuff. So just spend a couple of minutes with this particular table, and then you will be able to understand what is a T cell, like the staging of this particular tumor as well. Okay, so I hope you have understood. Now let's kind of move ahead and without kind of wasting more time. Okay. Now, the patient complains of fever, tachycardia, thyrotoxicosis. What is the diagnosis? Now, this particular question is absolutely incomplete. So, can you please help me? What was the question with this particular thing? Okay. So, anybody, can you please tell me what was the question with this particular stuff? Anybody, guys? What was the question? What was the question over here, guys? Can anybody tell me what was the question over here? I'm waiting for you guys. Can you please help me with this? What was the question over here? I'm not able to kind of get the actual recall of this particular question. High ESR rate was given. Okay. So it was given that the patient is having ESR is high. Was that given? Everybody agrees to this, that the patient, like it was given that the ESR is high? It is very relevant if at all it was given. Oh, history of sore throat was also given. History of sore throat. Right? What these things given? Ritika and Sneha Shri is basically trying to say high ESR and the sore throat. That's great. So, guys, now you tell me what is the answer to this particular question? If at all there was a history of a raised ESR and if at all the sore throat history was given, what is the answer to this particular question? Anybody? What is the answer? I'm waiting for you guys. What is the answer? So if at all these, but this was the history which was given, then the answer to this particular question is a D. quervins thyroiditis. Okay, no. It's not B. It's not B. No. See, guys, if at all they had given you that there was a raised ESR and there was a history of a sore throat, yes. The answer is okay. Over here, my bad. The numbering is kind of bad. I'm really sorry. I did not pay attention towards this. So yes, the answer over here is a D. quervins thyroiditis. Okay, yeah, absolutely right. Okay, so I did not know what's the answer. So like, what were the options and everything? So what you need to understand, all these exophthalmos, sweating, headache, goiter, all these particular things, whatever is given on this particular slide, these are the features of hyperthyroidism. And for the hyperthyroidism, there are all these particular causes. Now, the way in which you're describing in that particular thing, your answer of this particular stuff was granulomatous subacute thyroiditis. That is what is the answer to this particular question. If at all they had given you the history of a sore throat and all those particular stuff, raised ESR and all those particular things. So let me just kind of quickly walk you through what exactly happens in the patients with the D. quervin thyroiditis. Usually there is a young female. In the question, they usually give you young female, and they basically give you that there was a history of a sore throat. And then they basically give you that after 4 weeks, usually the timeline which they basically give you is after 4 weeks, the patient had pain in the neck, and along with this there was let's say what you call as there is the features of hyperthyroidism. Okay, so the patients are going to have a features of hyperthyroidism with the pain in the neck. So that is what is going to be the features in this particular patient. Now, why these particular things happen? Because there is let's say some kind of an immune system, or let's say some kind of viral illness, which basically leads to the destruction of follicles. Okay, so it leads to the destruction of the follicles, which leads to the release of the thyroid hormone. It leads to the release of a thyroid hormone, and this release of this particular thyroid hormone leads to the features of this particular hyperthyroidism. But this doesn't last for long. This is a transient thing. Okay, it is a transient thing, because once all the follicles have been kind of destroyed and the thyroid hormones are basically kind of going to come out, what is going to happen, the patients are going to land up into hypothyroidism, and ultimately the patients are going to become euthyroid. Okay, because this is a self-limiting. Okay, what is it? It is a self-limiting disease. It is a self-limiting disease. For the diagnosis, if at all, let's say you do ESR in these particular patients, that is what is going to be high. And if at all you perform an FNAC in this particular patient, what are you going to find on the FNAC? Okay, what are you going to find on the FNAC? So what are the features you're going to find on an FNAC? In the FNAC, you're going to find non-caseous granuloma and giant cells. Okay, so that is what you're going to find in these particular patients. Okay, so non-caseous granulomas and the giant cell, that is what you're going to find. So that is why the other names of this particular D. quervins thyroiditis is giant cell thyroiditis, okay, or granulomatous kind of thyroiditis. It is also called as a subacute thyroiditis. So all these are the different names of this D. quervins thyroiditis. And the treatment of this particular patients is you just have to give these particular patients NSAIDs, because to take care of that particular kind of fever, and let's say there is some kind of a fever also, some low grade fever might have also been given in your question or something like that. So the way you are describing, definitely no doubt, the answer of this particular question is a dequerence thyroiditis. Okay, right? So thank you so much, guys, for kind of recalling this particular question with me. Yeah, definitely the answer to that particular question which you're describing is, and as you guys are saying that in the comment box, that what had been given was a female, right? So yeah, like all these particular things kind of add up, and the diagnosis was definitely a dequerence or a subacute thyroiditis. Okay, now let's move on. There was a question of the shrugging of the shoulders in the neck surgery. Now, again, can you please help me with this particular kind of question, guys? Okay, so what exactly was this particular question? Was it being given that, let's say, after some kind of a neck surgery, or let's say after doing a neck dissection, the patient is basically having difficulty in shrugging of shoulders? Was this the question, guys? Okay, so the neck dissection was done, and after that, the patient is having difficulty in the shrugging of the shoulders. Was this the question, guys? Can you please help me with this? Please tell me, guys, what was the question? Waiting for your response on the comment box, guys. Okay, so can you please help me? What was the question? Guys, come on. Please help me. What was the question? Can you please help me with that? Hello. Patient is unable to move head right and left. Move head right and left, is it? Don't think so. Okay, so if at all, like the way in which the question was kind of recalled or something like that, yes, the answer would have been a spinal accessory nerve. Okay, so because that is what is supplying your trapezius muscle. Drooping of the shoulder was given. Okay, right. Okay, so yeah, all these particular things basically add up to this particular spinal accessory nerve injury. So what happens is that if at all there is an injury to the spinal accessory nerve, this is also called as a shoulder dysfunction. Okay, it's also called as a shoulder dysfunction. Okay, so it is also called as a shoulder dysfunction. So what you need to understand is that you have this particular spinal accessory nerve which is basically supplying this particular trapezius muscle, and what you need to understand is that if at all that is kind of injured, there's going to be the difficulty in the kind of there's going to be some amount of pain in the shoulders, there's going to be the drooping of the shoulders, there's going to be that is what is called as a collectively it is called as a shoulder dysfunction. Okay, so the characteristic history is that there's a shrugging of the shoulders a bit kind of difficult. Okay, so that's what you need to understand over here. So yes, the answer over here is a spinal accessory question, and this was one of the good questions, I would say. Okay, it's a good question. It needed you to have an understanding about the complications of your radical and the modified radical neck dissection in a bit kind of detail. So I hope you have understood that. Yeah. Thing was that it was a kind of a spinal accessory nerve injury. Now, what you need to understand is that what happens. Okay, so sometimes you appreciate that the spinal accessory nerve has been kind of injured intraoperatively. Let's say if at all the spinal accessory nerve is kind of cut, accidentally it is cut. So what are you going to do? You are going to suture it up. Okay, you are going to suture it up with the non-absorbable sutures, usually a very thin nylon. That is what you use in order to suture that particular nerve or repair that particular nerve intraoperatively. Now, after this particular surgery is done, the patients are going to have these symptoms. The patient is going to have a shoulder dysfunction, but the treatment of this particular stuff is that you have to undergo a lot of physiotherapy and exercise, and basically you have to give time because it takes around 3 to 6 months for this particular nerve repair to kind of take place, and it's going to take some amount of time. And let's say if at all intraoperatively you did not realize that the spinal accessory nerve was injured and 6 9 months have kind of gone by and the symptoms are still kind of severe, in that particular scenario you might have to kind of go in and kind of re-repair that particular nerve, but that is very rarely done. Majority of the times the treatment of this by the physiotherapy exercise, and you have to just wait for around 6 to 9 months for that particular nerve to kind of regenerate. So that's what you need to understand over here. Okay, understood. Now Again, this was, you can put this particular question in the category of a physiology or the surgery or something like that. But Valerian degeneration is basically something which is related to the injury to the nerves. Okay, so memory based question, nothing kind of major out of it. So what you need to understand is, let's say if at all this is a normal nerve, and if at all, let's say there's some kind of an injury to this particular nerve, what is going to happen is, so this is basically a kind of screenshot from 11 Bailey. So it is given in the surgery part. That's why I'm kind of covering it over here. So the nerve basically get disintegrated by the Valerian degeneration. Okay, so suffers from the physical injury. A portion of the lesion site, blah blah blah. The still a stump undergoes a destruction and the breakdown kind of produce the myelin debris. This degenerative process is referred to as a Valerian degeneration. So Valerian degeneration is basically a name which has been given for the disintegration and kind of destruction of that particular nerve, because whenever there is an injury, the myelons basically get destroyed. So that is what is called as a Valerian degeneration. And then the phagocytosis and the reconstruction basically starts, and over a period of time, let's say in 6 to 9 months, the nerve regeneration might take place. So that's all about it. And this is all about the Valerian degeneration, which you need to understand over here. Okay, right. Now, the gold standard investigation for the lymphangioma. Now, that lymphatic system is really, really not kind of leaving your back, right? So many questions, like one of the difficult questions was asked, I think, last time as well, right? So now let me just see how many of you, what is the answer according to you? Whether it is a lymphangiography, lymphoscintigraphy, or whether it is, let's say, a MRI or a USG. So first of all, were these the options, or like the options were something else? Please help me with this, guys. What were the options and what did you mark? So just tell me that. Come on, guys. What were the options and what did you mark? Can you please help me with this? Waiting for you a bit. Okay, so please put it in the comment box. I think obviously there's a bit of lag, but yeah, that's absolutely okay. Not an issue. Please put in the comment box whether this was the question, these were the options, and what did you mark. Okay, so what you need to understand is that whenever you have a swelling of the lower leg, you have to kind of investigate to exclude the other causes of the limb swelling to confirm whether it is involvement of a lymphatic kind of drainage only. So there are cardiac causes and the renal and the hepatic and the nutritional and the endocrine causes which can happen, which can affect the lower, which can lead to a lower kind of limb edema. And for these particular stuff, what you need to understand is the test which you can use is the blood tests and the echocardiography and whatever, all these particular chest radiography and the ECG and all these particular things can help you distinguish whether the cardiac, renal, and the hepatic and the nutritional system is the kind of a part of it. This is just the primary kind of elimination, whether the lymphatic system is involved or not. Then local causes of the leg swelling, whether it is superficial and the deep vein pathology or arterial, blah blah blah, all these things can be kind of excluded by the duplex ultrasound. Because if you understand, in the deep venous thrombosis also, what happens, there is a kind of edema which happens in the lower legs. It can be even a pitting edema and all this particular stuff. So if at all you get confused with this, yes, duplex ultrasound can kind of help you. But now when we have kind of significantly excluded, whether it's not because of the cardiac or the renal cause or something like that, now when we have narrowed it down, yeah, it is basically because of the lymphatic system, something like that. In that particular scenario, lymphoscintigraphy is something which is a very, very important investigation. So only these are the options. Okay, that's great. So guys, yeah, if at all these were the options, CT was there, blah blah. Anyway, so the answer is basically the lymphoscintigraphy, guys. Okay, so what you need to understand is it is a lymphoscintigraphy is the kind of a answer over here. So what you need to understand is, guys, now this is what you need to understand. This particular text which you're basically seeing on your slide, it is given in your 11 Bailey. So it is from a standard resource, and try to understand that is what is the answer over here. Lymphoscintigraphy is the answer. Okay, lymphoscintigraphy is the standard and the most commonly used investigation to evaluate the lymphatic function, as it has a high sensitivity and specificity for the lymphedema. Okay, such that the negative test effectively excludes the diagnosis. Okay, I hope you're able to understand this particular stuff. So lymphoscintigraphy is the kind of the best investigation for this particular lymphatic system obstruction. As per the options which are given to you, this is what is kind of there. Okay, now what you need to understand is that what happens in this? Okay, so what you basically do in this particular lymphoscintigraphy is that the radio labeled colloid is basically injected into the web space. So if at all you want to do it on the upper kind of thighs, so these are the web spaces, or in the lower kind of limbs, you have to kind of inject in between the toe and the second kind of toe. So the great toe and the second toe, between that particular web space, you inject this particular radio colloid dye, and then you basically look for the images every 5 minutes. Okay, every 5 minutes. If at all there is some distal obstruction, let's say proximally there is some kind of an obstruction of that particular in the lymphatic system, what is going to happen? What you have to kind of look for, if at all you get this delayed transit, it means that it is taking more time for this particular radiocolloid to kind of go upstream. Or let's say there is a prominent collateral, so whether like there's one particular main channel, and if at all the collaterals have formed a lot, or let's say if at all there is a distal cutaneous pattern. Okay, so dermal backflow, just try to understand, if at all you have injected into it, but rather than going into the lymphatic system, the dye is basically going at some, okay, okay, so rather than basically going into that particular lymphatic system, it is basically going into the cutaneous region only. So you watch for this particular terminology, dermal backflow. You have to kind of watch for it. Okay, that's come to kind of important. And reduced lymph node uptake. So if at all you find these particular stuff, delayed transit, prominent collaterals, dermal backflow going into the cutaneous system, or reduced lymph node uptake, if at all these things are there, then what you need to understand is that yeah, it might kind of give you the diagnosis of your lymphatic obstruction. And this is a direct line. Lymphoscintigraphy has largely replaced contrast lymphangiography. Okay, so I hope you have understood this particular stuff, guys. Lymphangiography is not the answer over here. Lymphoscintigraphy is the answer to this particular question. Okay, I hope you have understood this particular stuff. Okay, right now, CT and MR can be used, not an issue. It will provide, let's say, the dilated obstructed lymphatics. That is what you can kind of find, which is basically honeycomb appearance, fluid filled in the subcutaneous tissue. You can find these particular honeycombing in the subcutaneous tissue. I'm not saying that the CT and MR cannot be done. It can be done. That's fine. But that is not the best investigation for this. Okay, so that's what you need to understand over here. Okay, and the pelvic and abdominal blah blah blah, plus malignant cases. If at all, let's say you're dealing with some kind of malignancy, yes, you get a CT or MRI, because that is what is going to help you evaluate the primary lesion as well. But especially for the lymphedema, the best investigation out of the options which were given to you is definitely lymphoscintigraphy. Now, I want you to remember two more kind of things over here. Okay, lymph node biopsy should be avoided. Lymph node biopsy should be avoided. Essential, fine needle aspiration is the method of choice. So if at all they ask you that, should you do the lymph node biopsy? The answer is no, because if you try to do that particular lymph node biopsy in this particular patient, what you need to understand, you might end up putting in an infection into that particular lymph node, so it should be avoided. But if at all you have to do it, go ahead with an FNAC rather than a true cut biopsy. FNAC is something which you can prefer, and the genetic testing should be done for the primary lymphedema. If at all you are dealing with the patients of a primary lymphedema, then you have to kind of do the genetic testing. Okay, so I hope you have understood this particular stuff, and this is what is a image of a lymphoscintigraphy. I hope you are able to appreciate the dermal backflow. So over here, what you're able to see is a dermal backflow as well. Okay, now yeah, the answer over here is definitely lymphoscintigraphy. Now I'm just seeing one of the comments in the comment box that some questions were not in the exam. I'm seeing them for the first time, but I don't think so, because all of the other people are basically trying to give me the options, and they are trying to tell me whether this particular question, I think different set of questions. I don't know. Maybe. I don't know. Okay. I hope I understood. But I hope that this particular question was given in your kind of quick exam. And this is again an important kind of. So now the lymphatic system is going to become a like important topic in your kind of thing, because last year also one of the important question was asked, like a difficult question was asked over here. And obviously this was also not the mainstream question which you guys read. So yeah, that makes it a bit more of a difficult question. Okay. I hope you have understood this particular stuff. Now, let's move on to the next question. Now, this was again a very, very interesting question which they had asked you. I don't know how many of you guys answered it correctly or not. So, the neck contracture. Okay, so what is the treatment of a neck contracture? So, first of all, help me with whether the options were the same and what did you mark? So, please help me with this. What were the options and what did you mark? Please help me, guys. Please help me. What were the options of this particular question and what did you mark? Come on, guys, help me. Okay. Options were same. Okay, that's great. So let me just go back to the question. So guys, what was this over here? Gold standard investigation for the lymphangioma was there, or lymphedema? What was there? Okay. I'll come back to this neck contracture question. Okay, I'll come back to this particular question. I'll come back to this particular question. But somebody has raised a doubt whether here there was a lymphangioma, lymphedema, or somebody's basically trying to say investigation of choice for the lymph nodes. Can you please help me? What was it? Lymph node was there. Okay. If at all the question had lymphedema, if at all the question had lymphedema, then no doubt the answer over here is definitely lymphoscintigraphy. Lymphedema, definitely it is a lymphoscintigraphy. If at all it had a lymph nodes, if at all it had lymph nodes, then it varies. Okay, it varies. You can either do a CT scan or an MRI depending on what kind of a thing which you want to kind of see. Lymphangioma is not, yes. Okay, lymphedema. Everybody agrees to the lymphedema. Everybody agrees to the lymphedema, right? So if at all the lymphedema, I guess even I think so that lymphangioma would not have been there. I think so that lymphedema should have been there. Okay. Okay. Like the most common options, like thing which I'm kind of getting over here is a lymphedema. So if at all it is a lymphedema, then yes, definitely it is lymphoscintigraphy. If at all it was lymph nodes, then it would have been something. Coelography, no. Coelography question. Okay, okay. One and the same thing. Isotope lymphoscintigraphy. Yes, lymphedema. Okay. Okay. So it was lymphedema, and the answer is lymphoscintigraphy. Isotope lymphoscintigraphy, one and the same thing. Nothing major about it. Okay. So yes, the answer is lymphedema. It is like a lymphoscintigraphy. Okay. Now coming to this. Okay. So neck contracture is treated by, now if at all the options were the same, if at all the options, okay, was flap one of the options? Was flap given in the options? Coming to the neck contracture question, was the flap given in the options? Was flap given in the options? No, flap was not given the options. Now somebody saying flap was there, somebody saying flap was not there. Was flap in the options? I would rate this as a good question again. So even this was a good question. No, sir, I don't think flap was there. Release, incision, and pressure packing. No, 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 that's not there. Okay, let's try to understand how do you manage. If at all the options were the same, then it would have been kind of a separation with the full thickness grafting. If at all the options were not like this, if at all the flap would have been there, then flap would have been a better answer. Okay, flap would have been a better answer. Now again, okay, so this is how the neck contracture is there, and yeah, you kind of want to treat it. That's fine. Now this is what you are basically seeing on your screen. Again, this is a screenshot from your Love and Belly. So this is Lemon Bailey trying to teach you how do you kind of treat the contracture. Let's kind of read it together. So some contractures can cause severe functional, psychological, and the aesthetic problems. Yes, as you can see over here, the patient is not able to kind of extend the neck, and obviously it doesn't look kind of very, very cosmetically sound. That's what you need to understand. Contracture across the joint may restrict the range of movement, leading to the deformity, blah, blah, blah. Contractures may also cause, that's fine. Okay. Now, the surgical contraction release and reconstruction can be an effective treatment option. So we all agree on that we have to kind of release this particular contracture, and then we have to kind of go ahead with some kind of a reconstruction. A key principle in the kind of a replacement of the scar tissue is with the healthy tissue. a wide range of reconstructions are described. So what they're basically describing in the summary box is all these particular things: split thickness graph, full thickness graph, grafting, like local flaps, and just healing by the primary intention, secondary intention. All those particular options are there. Okay, that's fine. And typically involve the skin grafts and the flaps. So what they're basically trying to say, that if at all you want to treat the contracture, now there are a lot of options, but the logical options which you have are either you have a skin grafting, okay, you have either the skin grafting or you have flap. Okay, so these are your logical options. Okay, so what they're basically trying to tell you, that you have the logical options of skin grafting and the flap. Okay, everybody is with me till over here? I hope you are. Okay, now the local flaps such as the Z-plastine and its variants can be used to kind of blah blah blah. So there are various types of the local flaps. In here, what kind of flaps are we talking about? We're talking about the local flaps. I hope you have heard of this Z-plasty and the YV-plasty and the VY-plasty and all those particular stuff. So all these are the local flaps which you're talking about. Free flaps may be required for, that's fine. So free flaps, you can use the free flaps as well, but most of the time what is required is a local flap. So Z plus T, VY plus T, YV plus T, all those particular stuff. In general, this is what is going to give you answer, right? So in general, flaps are preferable to the skin grafts because of the graft contracture. When the skin grafts are used, full thickness is preferred to the split thickness, as they have a better texture and the contract less during healing. Okay, so I hope you have understood this particular stuff. So what they are basically trying to tell you, if I want to summarize in one line, for a contracture, for the treatment of this, the best is the flap. If at all that is not given in the option, then you have a full thickness skin graft. And if at all that is not given in the option, you have a split thickness skin graft. Do you understand this particular stuff, guys? Okay, so what are the options you have? Best is the flap. If that is not given in the option, full thickness skin grafting. If at all that is not given in the options, split thickness skin grafting. Everybody have understood this particular stuff, guys? Everybody have understood? Yeah, right? So why not pressure packing with release incision? Okay, okay. So what we need to understand is, why not kind of release incision with the pressure packing? See, if at all you are basically trying to give a release incision, and followed by that you are basically going with the pressure packing. Try to understand what you're doing. In this particular scenario, what you're basically facilitating is that particular raw area which you have created is going to kind of heal with secondary intention. Okay, so here what is going to happen, if at all you basically give the release incision, you're not going to cut the neck, obviously, just going to cut that particular contraction, and if you put a kind of pressure, kind of compression over it, what is going to happen is that you are going to kind of make it heal by the secondary intention. And what do we know about the secondary intention? Healing by the secondary intention, it has a worst scar outcome. Okay, so obviously, I mean, it's a free India, it's a free world, anything can be done, anything is being done. But what you need to understand, idealistically speaking, if at all you have to kind of treat a kind of contracture, the best thing is basically the flap. If at all that is not available, then full thickness skin grafting. The reason why the full thickness skin grafting, as you can see over here, it has a better texture. It is basically same as the normal skin, and it has a, like, the contraction is kind of less. So what you need to understand is that there's something which is called the primary contraction and the secondary contraction. Primary contraction is more with the like full thickness skin graft, and the secondary contraction is less with the full thickness skin graft. So if at all the secondary contraction is less, that is going to be favorable, and that is the reason why the full thickness skin graft is more preferred as compared to that of a split thickness skin graft. Okay, I hope you have understood this particular stuff, guys. Everybody have understood this particular thing? So yeah, that has to be the kind of sequence. Now I don't know whether the flap was given in the option or not, but if at all the flap would have been given, flap would have been the answer. But if at all the flap is not given, the answer is definitely whatever the separation, incision, whatever you want to give, and then full thickness grafting. That is what is the answer. Okay, I hope you have understood this particular stuff. Understood? Got it? Right? Flap was not then the option. That's great, not an issue. So if at all next time they give flap, that is what is going to be the answer. But if at all flap is not given, full thickness skin grafting is the answer. So I hope you're able to understand this. When skin grafting are used, full thickness is preferred over the split thickness graft. Not my words, words from your Love and Bailey. So yeah, that's what is the Bible of your general surgery. I hope you've understood this particular stuff. Understood? Got it? Okay. Now moving on to the next question. A full kind of term delivery boy with a whatever unilateral cleft lip, and the parents are concerned what could be cause of it. Okay, so basically what they were trying to tell you about the embryology of the development of your kind of the lip and whatever the all those particular stuff and all those particular thing, right? Now I'm pretty sure that you would have read this in great details, but what you need to understand is over here the answer is medial nasal process with the maxillary process. So why does the cleft lip form? Cleft lip is basically formed if at all there is some problem in the fusion of your medial nasal process with maxillary process. Okay, so if at all there is a problem in the fusion of this medial nasal process with the maxillary process, that is what is going to give rise to your cleft lip formation. Okay, I hope you've understood this particular thing. I'll just quickly revise your embryology. I'm pretty sure that you guys might be knowing it better than me, but let's kind of revise it like just for your sake. Okay, so in the third week of gestation, what happens? The three germ layers are kind of present: endoderm, ectoderm, mesoderm, and then basically the craniocaudal kind of whatever the rotation and the lateral rotation of those particular the plate is basically going to take place, and ultimately there is going to be the formation of your pharyngeal arches. Okay, so many things happen in between and all this particular stuff, but by the fourth week of gestation, what happens? There is the formation of a pharyngeal arches. Now the first pharyngeal arch is the one which basically splits into the maxillary process and the mandibular process. So it basically splits into the maxillary process and the mandibular process. Okay, so ultimately what you have a frontonasal process, nasal process, then you have a maxillary process, and then you have a mandibular process, and in between what you have is a stomatidium. Okay, so you have this primitive mouth opening, stomatidium. That is what you basically have. Okay, so I hope you have understood this particular stuff. Frontonasal process, maxillary process, mandibular process, and then the blue colored thing which I have kind of drawn is a stomatidium, primitive mouth opening. That's fine. In the fourth week, what happens is that the two patches, blah, blah, blah. And what you need to understand is that the ectoderm in the frontal kind of prominence, blah, 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 thickening, nasal placode formation basically takes place. So here in this particular frontonasal process, what happens? There is a formation of a nasal placode. Okay, there is a formation of a nasal placode in this particular frontonasal process. Okay, so this frontal process, there is a formation of a nasal placode. So frontonasal basically appears later when it basically comes down. That's what you need to understand. But in the frontal process, there is a nasal placode formation. Now, this nasal placode is further subdivided into the lateral nasal process and the medial nasal process. So ultimately, what happens is that there is a formation of lateral nasal process, medial nasal process. Over here also there is a happening on the two sides, right? So there is a lateral nasal and the medial nasal process. Over here what you have is a maxillary process which is trying to come over here, and then there is a mandibular process which is over here. Okay, so this is what is basically happening, and over here there is basically a frontal process or a frontonasal process, whatever you want to call it. Okay, so not a very great diagram. I'll show you the images, but that is what is basically happening. So the nasal placode has got converted into this lateral nasal process, and this is what is your medial nasal process. Here there is a maxillary process. Over here there is a mandibular process. Okay, mandibular process. Okay, I hope you have understood this particular stuff. Now, so the nasal placode proliferates into the nasal pit. So blah blah. That nasal placode forms the nasal pit, and then the maxillary process, it basically proliferates medially, and then it comes and kind of fuses with the medial nasal process by the bucco-nasal groove. That's fine. By the sixth week, what happens? The maxillary process fuses with the medial nasal process. So that is what you need to understand. by the 6th week, what is happening? The maxillary process is basically fusing with your medial nasal process on the each side, and that is what is going to give rise to the formation of an upper lip. Okay, that is what you need to understand over here. Okay, let's come directly to this. Okay, so I'll just recollect what I was trying to tell you. So there is a frontonasal prominence, and then there is a maxillary process, and there is a mandibular process. Okay, then there is a formation of a nasal placode, which further gets divided into the medial nasal process and the lateral nasal process. Now, what happens? By the end of 6th week, what is going to happen is the maxillary process is going to fuse with your medial nasal process, and it is going to kind of lead to the formation of your upper lip. So the most of the part of the upper lip is basically formed by this particular maxillary process, but this philtrum of the lip is basically formed by your medial nasal process. Okay, what about this lateral nasal process? Lateral nasal process is going to form the lateral portion of your nose. Okay, so that is what is going to happen. Now, this medial process, which is basically fusing in between, so this is what is called as a intermedial kind of nasal prominence, whatever, that is what is going to give rise to the formation of a primary palate. And then what is going to happen? The nasal shelves, the secondary palatine shelves, are going to come from the lateral aspects. Okay, so they are basically going to come from the lateral aspects, and they are going to fuse in the center. So ultimate outcome is that if at all there is a problem with the fusing of the maxillary process with the medial nasal process, the patients are going to have a cleft lip. If at all there is a problem in the fusion of a primary palate means this one, which was basically given rise by this fusion of this particular medial nasal process, that particular stuff. So I've kind of written over here the intermaxillary kind of segment, which develops into the nose philtrum, upper fourth, blah blah blah, and the primary palate. So this primary palate is basically given by your intermaxillary segment. Okay, so that is basically the part of the medial nasal process which have kind of fused together. So if at all there is a problem between the fusion of a primary palate and the secondary and the two palatine shelves which are coming, that is what is going to give rise to your anterior cleft palate. And if at all there is a problem with the fusion of the two palatine shelves, that is what is going to lead to the posterior cleft palate. So from the clinical point of view, what you need to understand is this is what is a clinical relevance of your embryology, which you basically kind of read. So just kind of remember that. But I've just tried to revise your embryology in a bit kind of a fast format. I'm pretty sure that the anatomy faculty will kind of do a much better job in revising it. But I was just trying to kind of make you understand it from the surgical aspect or surgical point of view or something like that. Okay, so I hope you have understood this particular stuff. Okay, now which of these is kind of true about the cleft lip? So more commonly associated with the congenital syndrome. So yeah, it is associated with the congenital syndrome, but most commonly, okay, so let's kind of take it one by one. The answer, I hope that the answer, like the options were same only. If at all there was some kind of a discrepancy, just put it up in your kind of comment box. But over here, the answer was the left sided is more common than the right one. That is what is the true one. Okay, so let's kind of walk you through it. Okay, so the first option which was given to you, most commonly associated with the congenital syndrome, the answer is no, it is basically false. Because what you need to understand is that even though it is associated with a lot of congenital syndromes, but what you need to understand is that palate occur as an isolated deformity. Most cleft lip and the palate occur as an isolated deformity, even though it is associated with many kind of syndromes, no doubt about it. But most of them are going to occur isolatedly. So most common syndrome which is associated with this is a peri-Rubin sequence. Now what is this peri-Rubin sequence? So peri-Rubin sequence is this. Okay, so where there's basically triad of a micrognathia, then glossoptosis and cleft palate. Okay, so that is what is a triad of. This is what you call as your peri-Rubin sequence. Then the other syndromes which are associated with this are Stickler syndrome, where there's an ophthalmic and musculoskeletal abnormalities. Then Shrimpson's kind of syndrome, where there's a cardiac abnormality. Then there is a Downs, there is Appert's, and there is a Treacher-Collins syndrome. Okay, so all these are the syndromes which are associated with this. This is what is the image of a Treacher-Collins syndrome. So again, there is a kind of a, you can just go through it. Okay, so that's what you need to understand. These are the syndromes which are associated commonly with the cleft lip and cleft palate, but most of the cleft lip and cleft palate are occurring as an isolated anomaly. That is what you need to understand. More common in females. So what you need to understand is that cleft lip and lip plus palate are more common in the males. Okay, but if they specifically talk to you about isolated cleft palate, if at all it is an isolated cleft palate, that is what is more common in the females. Okay, so I hope you have understood this particular thing. Isolated cleft lip along with the cleft palate, that is what is more common in the males, but isolated cleft palate, that is what is more common in the kind of females. So even this was kind of false. Okay, so cleft palate lip is not common in your females. Now bilateral cases are more common and left-sided is more common than the right. So this was kind of false and this was basically the true, and that is what is your answer. So yes, left-sided is more common than the right one. So unilateral cleft lip is more common than the bilateral cleft lip. That's what you need to understand. Unilateral cleft lip deformities are more common on the left side. So left is more common that is compared to the right one. 60-40 ratio is there, but yeah, it is more common on the left side as compared to that of the right one. And the typical distribution is overall, the most common anomaly is cleft lip plus the palate. Okay, so isolated cleft lip, isolated cleft palate, cleft lip plus the palate. So lip plus palate is the most common one. Followed by this, isolated cleft palate is the second most common, and then the isolated cleft lip, that is the third most common one. Okay, so I hope you have understood this particular stuff, guys. Yeah. Okay. Right. So that was about the paper which you had, guys. Now, before I just stay with me, You have stayed with me for this much amount of time, so just stay with me for a couple of more minutes. That's fine. If at all, you can just go through these particular kind of things which we are basically going to offer, pre-recorded videos, all those particular stuff, and whatever, the exclusive Q bank and your comprehensive test series, and kind of clinical world also, and hard copy notes. So over a period of time, whatever the recordings which we are going to do, I'll be going to cover the surgery aspect for you guys, and those particular things will be available for you. And yeah, like, you can kind of go through and you can kind of revise it along with it. So if at all you wish, you can just come and you can join this particular program with all of these people. And yeah, like, obviously I'll be there as a faculty of general surgery, and then you have the esteemed team and the esteemed faculty for the other subject as well. Now, lastly, what I wish to kind of cover with you guys is that your paper is over, that's fine. It was not that an easy paper. Like, a couple of questions were really, really tricky, and they were really kind of nice questions. So that's what you need to understand. And don't be disheartened and all this particular stuff. Many people would have already told you. I will not kind of tell you about all those particular stuff. Obviously, if at all you don't get ranked, obviously you will feel bad. There's no way around it. You should feel bad a bit or something like that. That's fine, because that was your goal. And due to XYZ reason, maybe some circumstances or the paper or whatever XYZ reason, it's okay. But at the same time, see, try to be grounded. Whatever life throws at you, even if the life throws at you the rank of 10 or something like that, that's really great. Congratulations from my end for the first time. But what you need to understand is that that's not the end of the story, right? Still, you have a lot of long journey ahead of you. And even if, let's say, you are not able to secure the rank of your choice in this particular exam or something like that, yeah, feel bad. That's fine. Couple of days, take yourself, try to do the self introspection, reassess, and all those particular stuff. And yeah, take a decision whether you have to kind of read for this particular exam again or not, or something like that, and then restart. I mean, not that particular restart song or anything like that, but you have to kind of get going. Put your frustration, put your anger into the action. That is something which you have to do. Yeah, that's the kind of the whole gist of it. It's basically, life is a marathon, guys. Okay, it's not a sprint, so it's okay. Don't worry. Nothing is final. Nothing is kind of absolutely determined. So it's okay. Take one day at a time. But by and large, this paper was decent. It was not that easy. It was not that difficult. It was kind of a balanced paper. It was a decent paper. Okay. So if at all any queries, anything, if you wish to have a word with me, or if you want to talk to me or something like that, yeah, please let me know or something. And yeah, kind of please have a word. I'll be here for a couple of minutes and then I'll kind of take it off. But yeah, I hope you gain something from this particular session. And thank you so much for making me kind of recall a couple of questions for you guys along with this particular session or something like that. Thank you for your time, and I hope you gained something out of this particular session. If at all you have any comments, any doubts, please do put it in the comment box. I will kind of answer it personally. I'll definitely do it. And yeah, thank you so much. I would love to interact with you guys. So if at all you have anything, please do put it in the comment box and I'll be more than happy to kind of interact with you. Okay, all the best, guys. It's just an exam. Life is too big. So all the best, and I'm pretty sure that you're going to do very well, not only in this particular exam, but also in your life. So yeah, take care. Bye-bye. Have a nice day. Great time. Bye-bye.